what you're saying, I think. You okay, sir? Sorry about that. So we're going to keep you awake for the very beginning until we get to where we need to be, and then I'm going to put you to sleep, okay? If you feel any discomfort, you just tell me. Say, ouch. All I ask you to do is just don't move, okay? Try to lay still. Are you comfortable where you are? All right. Remember, you just let me know it's uncomfortable by saying, ouch. Shot. Which side are we seeing? Oh, don't just take shots. You're zoomed in too much, first of all. Oh, way too much. All right. All right. Shot. Give me a lateral, please. Generally, I like a lot bigger field draped out than that.
Like, okay. Just in case you need to, yes, sir. What is this, sir? What is it?
No. What is it? We don't need the suction on yet. Shot. I need to see probably just a little bit. I think we're okay. Are you comfortable? AP. That looks too low. I mean, too low, too high in the foramen. Really not getting a good picture of 5-1. Can we do better on the lateral view, please? Yeah. All right, it's not bad. Go back to a lateral. I need it more zoomed out. Are you all the way to the ground with the fluoro? Yes. That's better. So let's get those end plates lined up. They look pretty good. Just keep an eye on them. Huh? Let's see. No, just leave it for now. Let's see if I can get a little lower. Shot. It's just really hard to see the top of 5, huh?
Well, it's 4 or 5 is few.
Yeah, I know. But you should still be able to see it. It's better. Shot. Give me an AP, please. So our patient, I don't think he... Sir, did you know you were getting a fusion at 045, or did they just fuse automatically after your surgery? You did? Yeah, so... Shot. Let me have a lateral. I can't see that. All right. Shot. Shot. I mean, I feel. Shot. Shot. Give me an AP. Well, we're definitely at 5-1. Question is, am I close enough to the disc? And the answer is no. He is rotated quite a bit, but I think we're too far lateral. And you have the lateral view is there. We're actually pretty close. Shot. Lateral. Force lateral. Shot. AP. Not terribly happy with that. What I really need is a true AP. I don't feel like we have it. Let's try rotating the arc one way then the other. Let's just see what happens. Worse. That's I think that's a little better. We're too lateral. Hello, Monica. What's going on? Shot. Give me a lateral, please. Shot. I think he's just rotated. That's why we're having a hard time. Are you comfortable?
Yeah, good.
Good. Just checking. Shot. How bad is that on a scale of 1 to 10?
I don't have anything.
What was the highest it went to?
Pardon me?
That pain you just had, how high did it go?
Oh, I don't know, 6,
Huh?
6, 7.
That's it? You almost came off the table.
Yeah, it was sharp.
I mean, what's the highest it went? You don't have to be a tough guy.
I don't know. Got 7, 8.
All right. Was that where you get pain typically in your back?
Lower, usually lower.
You have pain in that area at times?
Yeah, I get that up in there too.
So 5-1 is 8/10 concordant. All right. Well, we found one of the 3 painful discs. Now we're gonna work on the other 2. Yeah, you should always be past midline, if about this much, so I can see across
sir.
to the other side.
Yes, sir.
And there's no reason in the world to make a small window. There's not minimally invasive draping. It's minimally invasive surgery. So you want to drape and prep way up here and drape up to here. This is fine where you are here. And this I would definitely have gone lower down. Just to right where the butt crack is starting to get in.
Yes, sir.
You know. Like right to about here, draped. Here is fine. Here, higher up. Here, over to the side.
Perfect.
You want a big window.
Yes, sir.
It's amazing you could be in all these cases, right? How many of these lasers have you done?
Probably I will say like a 15 maybe.
You feel that?
Okay, welcome back.
Okay. 50?
No, 15 and 15.
Oh,
probably.
15. Little numbing medicine, all right? Yeah. It's amazing how much people don't pay attention to until they have to, isn't it? What did you say? Mike doesn't want to scrub. He was given the opportunity. He said that it would, he doesn't want to do anything that might ruin his nail polish. That's correct. I love it. All right. We need the table lower or the fluoro higher. Good. All right. So you can see where the fusion is. We're going to go for the other level and we'll see what happens here. Remember, let me know if it's uncomfortable for you.
Okay.
I mean, I know none of this is tremendously comfortable, but
Well, I kind of been through it. I don't think it's much to bother me.
we're going to get you asleep soon. Shot?
Okay.
All right. So that's, I need to really see higher up now with the fluoro. Let's get that tube out of the way because you can see it's about to block our view. That's it right there? Ah. All right, so that's not too bad. Shot. 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 Yeah, feel the arthritis. Shot. Where do you feel it?
In the back.
How do you know where I'm sticking a needle? All right. Fair enough. You got me on that one. No, I don't need an AP. I just need to be able to get into that next disc space, which is going to be super hard to do. I could probably do one incision here. Certainly is not easy. I could probably get the next level with the same. The question is, which incision should I try to go for it from? Well, I mean, I can go this way, but I could also go this way here. Hmm? That's what I'm thinking. The lower one may give me a better angle. Question is, though, do I do two separate incisions or one? Well, I don't know. They're so close together. See that? All right. I have to make them anyway. Yes, we have a question?
We do. We have a viewer who's saying, I had surgery on my back in 2015 from L1 to T4. I've been in pain every day and have nerve damage too. Would this surgery be able to help?
All right. So let me get this straight. They've had... I missed the very first part of the question. I apologize. What did it say?
They said, I've had surgery on my back in 2015 from L1 to T4.
Okay.
I've been in pain every day and have nerve damage too. Would this surgery be able to help?
So, first of all, thank you for asking the question. Yeah, we encourage people to ask questions. That's the whole idea, so that I could try to answer them. But the truth is that without knowing more information, it's impossible for me to tell you if the surgery could help. If you're correct, and it truly is L1 to T4, that means you have L1, 2, L2, 3, L3, 4, L4, 5, L5S1 discs that are still mobile. It sounds like you've had a thoracic fusion. So it really comes down to what's causing your pain. I need an MRI and I need to do an exam on you and probably a CAT scan to be able to tell you for sure if this surgery would fix your problem. What I can tell you is this: if your pain is coming from a herniated disc or a pinched nerve, the answer is yes. This surgery would be fantastic for you. If your pain is not coming from a pinched nerve, then no, this surgery would not work for you. That's interesting. Far too superficial for anything deep. Huh? Did I just happen to get a muscular vein? Yeah. I mean, let me have, thank you. Let me have a rolled towel. So I don't, yeah. I mean, that's not Coumadin, that's, you know, yeah. So I'm going to take a minute and just apply some pressure. Now, to answer your question, if I could do a little better job, I'm going to try. I guess what I'm trying to say to you is, if your pain is coming from, you said you had spine surgery, L1 to T4. If your pain is coming from the L1 to T4 region, could this surgery that you're watching now help you? The answer is yes, as long as you didn't have a fusion from L1 to T4. So if you had a fusion there, I might have missed it, but then in that case, this surgery probably won't help, but it still could. It's just less likely. Now, if you did not have a fusion, which I don't know what kind of surgery you had done, but if you did not have a fusion and you only had like a laminectomy, then there's a very good chance that surgery on the disc would help you. However, here's the problem. The endoscopic surgery is only for cervical and lumbar spine, cervical and lumbar spine, not thoracic spine. So if you have a problem between T4 and L1, there's only one disc we'd be able to fix with the endoscopic surgery. Okay? And so, again, I need much more information. I really need to know what kind of surgery you had and what were the exact levels. Was there a fusion or no fusion? And I also need to know, where is your pain currently? Is it below the prior surgery? Is it at the area of the prior surgery? That's what I've got to figure out. So all those variables are very important in determining what's the best treatment for your problem. I think if you want to really to understand the crux of the issue, we can help you with your pain. I think that, at Duke Spine Institute, we're able to help probably about 95% of people that have chronic back or neck pain. There's about 5% of people that, there's nothing that we can do to help them. But it's rare for us to have those kind of patients where we can't help them. So I would say there's a very good chance that we'd be able to help you, but I need a lot more information. How's he doing? All right. I don't feel any kind of a hematoma, which is good. And we're just going to go for that disc again. So, shot. 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 Once more. All right, let's go AP. Tell me when you're ready. Shot. All right, we're getting closer to the facet. Where's the lateral view there? Okay. Shot. And give me a lateral. So in case anyone's wondering, are we able to do surgery on patients that take blood thinners? The answer is yes, but they have to be shot off the blood thinners. I'm not really happy with that view. Shot. 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 You can see I'm just getting caught up right on that facet. Are you uncomfortable there? Shot. Huh? You feel pain anywhere? Shot. Shot. I think maybe caught on the inferior end plate. Shot. Give me an AP, please. See, I don't think we have the end plate lined up well. That's the problem. I need the table up or the fluoro down on that next lateral that we do. Go ahead. Yeah, it looks good. Now lateral, please. I need that end plate lined up. Looks like we're hitting, hard to say on the AP, but it looks like we're hitting the superior end plate. If I had to guess, I'd say we're up against a superior end plate. Yep. That's exactly what we're doing. That looks like a pretty good lateral. So we're up against a superior. So I need to turn and go north. Shot. Mm-hmm. Shot. Why does it look like it's changed? I must be on a pretty big bone spur. There it is. Shot. That's tight. Deflecting down. Interesting. Very tight. Am I going to have to say goodbye to one of my tubular retractors today? Mm. Yeah, good point. Good point. That's smart. All right. So we've already done that guy. That leaves these two. Sir, are you comfortable? Huh?
Okay.
All right. Where do you feel that? All right. How bad did it get on a scale of 1 to 10? 4. You took Percocet before you came, right?
Yeah.
Okay. And is that where your typical pain is?
Yeah, he's a little more.
All right. So far we've done discograms at 3, 4, and 5, 1. How bad is that on a scale of 1 to 10? Big tear. All right. So you can see the giant tear there in the back. Go ahead and get an AP. We're going to put you to sleep. When you wake up, we'll be done with your surgery, sir.
All right, sir.
Have a sweet dreams.
Okay, thank you.
Can you count from 1 to 100 for me?
Okay.
Out loud. By ones.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19.
Lower the floral. All right, bring the table up, please. Shot. That's it right there. All right. I want it zoomed out a little bit. I think you're too magged in. You're doing great. Keep counting. Shot. Shot. All right, so we're going to slide this spinal needle out over the guide wire. Shot. Right. And we got 2, 3. I need to make an incision, I think. Yeah. So, Mike, is he right? Is that something you're interested in?
No, thank you.
Yeah, I thought we talked about it. You don't want to scrub, huh?
No, I'd rather be, what I want to do is be a PA in the ER. That's my goal.
PA in the ER. Why?
Do I shadowed in the ER? I think I'd like it. I used to work for the fire department. I kind of like that.
Nice.
Over there.
Yeah. Huh? Adrenaline junkie. Yeah. No, nothing wrong with that. We need people in the ER. I can't see, Louise. Yeah, better. I could see it too. But I will warn you, it can be quite disturbing. Huh? No, I mean the things you'll see in the ER will bother you. No, you never become numb. Not if you care. Neurosurgeons spend a lot of time in the ER. Yeah. Huh? Oh God.
It's
Yeah.
not good what you see in the ER.
Huh?
It's not good what you see in the ER.
No. No, you'll see stuff that will change your view on life. I had a PA when I started about, what, how long ago did I start? 2004? And he was he was a nurse first and then a PA. Shot? And he would tell me some of the stories about the ER, stuff that people do you couldn't even imagine. Nothing wrong with being a PA. Take. All right. So, yes, we've taken our dilator down through the tissues right into the disc. And now we're coming over the dilator with our tubular retractor. For those of you who have not seen one of these before, this device I'm putting in right now is a metal tube. The whole surgery will be performed through this metal tube. The diameter of the metal tube is 7 millimeters on the outside. The internal diameter is around 6.2 millimeters. So I have 6 millimeters basically to work in. Shot. Nice. I don't want to trap the dilator. Shot. Otherwise the dilator will advance. Shot. Which it's doing. I think that's good. Nice, Luis. I like how you're prepared. The beauty of this surgery too is that the incision is small. The working channel is small that we go through. And because everything is so small, patients recover very quickly. Okay, we're ready. Ready to start on our first disc. For those of you who don't know this, this is the Deuk laser disc repair. Luis, do you see this?
Yes, sir.
Anything wrong with this? What should this line up with? Yeah, let me do it. Okay, and then this tightens down. This is all the way open. That's a good way to lose that pin. Okay. All right, I'm going to need, I never have the suction open. I'm going to need a pituitary. I'm going to need the pedal. Pedals here. Great. Yeah, that's what you want. You want it to just take it straight down. So I'm introducing a pituitary, pulling out any pieces of herniation I can grab right here. All right, laser. Zach, any questions from the audience while we get started here with our first disc? This is the right L23.
Not yet.
Just a little blurry. I don't know if it's the dye. That's better. So one of the stories I could tell you about the ER, because I worked the ER in a place called County Hospital Los Angeles. You might have heard of it. As a medical student, we rotate through the ER. And Los Angeles and County Hospital Los Angeles is in the center of the gang territories of Los Angeles. So all the gangbangers come in to the emergency room for medical care. Somebody shot out on the street, the ambulance pick them up, bring them to the hospital, and then we try to save their life. So at any given time, County Hospital LA would have 5 gangbangers in the hospital, in the ER or the operating rooms getting operated on. At night, I used to sit in the dorm at the hospital and I would have my window open. I could hear gunfire all night long. Literally, brrr, brrr, bang, boom, boom, all night long, every single night of the week. Literally a war zone, Southeast LA. So one of the gangbangers came in, and I had the pleasure of taking care of him. And he had a hole blown through his testicle into his thigh from a bullet wound. Apparently, he was on the street doing something he's not supposed to be doing, and the police showed up and said, "Put your hands in the air." And of course, instead of putting his hands in the air, he started running with a gun tucked away in his belt under his belly. And as he reached for his gun to pull it out and start shooting at the police officers, he accidentally pulled the trigger and shot a bullet. Yeah, right? So we had to fish reproductive tissues out of his thigh for about an hour. Yeah, the ER. Can't say I missed the ER. Stand by. There's a big piece of herniation. Thank God for the ER though, right? How many lives are saved there?
We have a question.
Yes.
We have a viewer asking, how much disc material does the surgery remove in each disc?
Zach, you want to take that one?
I think it's about 10%, about.
Yeah, on a big herniation, it's about 10%. On a smaller herniation, it's about 5%. So we're taking anywhere between 5 and 10% on average. In other words, not very much. And the most important thing to understand is we're not taking the normal disc out. We're taking the part of the disc that already herniated. So it's already abnormal, not normal. It needs to come out anyway. So it's not like we're taking part of the good disc out. You have any good ER stories there, Dr. Santiago? I don't know why it feels like it's slowed down. Are we still at 10?
Most of the stories are not good.
That's better. What'd you do?
Somebody.
Huh? Oh, thanks. Stand by. I was wondering there was a change. Sorry, Dr. Santiago. Go ahead.
No, pretty much most of the ER stories are not,
Nothing we can talk about in the OR in public.
bad stories.
Sad stories, yeah.
Well, one that goes around your line of work, obviously, it's the south side of Chicago. A lady comes in. She was dragged pretty much on the road for miles.
Accidentally.
Huh?
Dragged on the road for miles.
On the road. She was attached to a car and dragged on the road. Pretty much, it was a horrible scene.
Yeah.
Had to be bilateral craniotomies to decompress the brain.
Yep.
And, after we finish with her, we just have to scrub her whole body just to get the gravel from the floor.
What happened to her?
Well, last time I saw her was in the ICU.
No, but I mean, what happened? Like, how did she get her injuries?
Well, someone dragged,
Oh,
dragged
ran
her
over.
down to a car, and she was dragged on the road.
It was intentionally dragged.
Yes.
Jesus
Even on the
Christ.
drag.
Yeah.
So
That-
pretty much most of the scene was
That's horrible.
was
Horrible, horrible, horrible. That's the kind of stuff we're talking about, Mike. That happens a lot. Things like that come in, and it's so disturbing.
We spent pretty much the whole night in the OR, taking care of, multiple teams, lifting a leg, opening the skull, it was a nightmare. All night long.
Well, I've seen a lot come in. Stand by.
She was alive, but obviously she has massive brain injuries.
Did they ever find out who did that to her?
I don't know. I was in training at that time. I'm on rotation, so I left the hospital and she was still in the ICU.
Yeah. You never forget a story like that. It's sad. It's sad what people can do to each other. Animals. So, the worst thing that I ever witnessed in the ER was at UF in Gainesville. UF is a college town. Gators, a lot of college students. And there's a certain condition that occurs from a bacteria called what is it? Neisseria meningitis, right? And there's something unique about this bacterial meningitis in that it spreads very, very quickly, and it's a bacteria that colonizes, I believe, the nose, the nasopharynx, and gets into the bloodstream and will cause headaches, and you'll see a rash on the skin. And this girl came into the ER. I was on the plastic surgery service at the time. She was 16 years old. Really attractive young lady. Perfectly normal prior to this. She started developing a rash earlier in the day on her arm, and then another one on her leg, and her head was hurting. Severe headaches. Came to the emergency room. By then it was too late. They gave her ciprofloxacin. She went into DIC, disseminated intravascular coagulation. and she lost the pulse in her right arm. So plastic surgery was on for amputations. And the decision was made not by me, but by my attending, that she should have her arm amputated because there was no pulse. And it was gonna, it had to be amputated. So we took her to the OR to amputate her arm at her shoulder. And while we were in the operating room, her other arm lost the pulse. So she became a double arm amputation. As we were amputating her arm, her leg lost the pulse. And then the other leg, and she became a 2-arm and 2-leg amputation. And then she died on the operating table. Saddest thing I've ever seen in my life. Saddest thing I've ever seen. And to think that could have been prevented by an antibiotic if she had just gotten to the emergency room faster. Neisseria meningitis.
To my daughter.
Huh?
I just gave that vaccine to my daughter because she's gonna go to a sleepaway camp.
Yeah.
And we consulted with the pediatrician, and they say, you know what? I think it's a good idea.
I didn't know there was a vaccine for it.
It's a vaccine.
For Neisseria meningitis? Huh. Well, lots and lots and lots of bad stuff. But, like I said, thank God there are doctors to care for those patients that really, really, really need it. I talked to the ER doctor after that, the head of the ER, and I said, have you ever seen anything like this? And he said, every year we get somebody like this that comes in too late. But any kid that, comes into the ER, they just give them a dose right away of antibiotic to kill Neisseria meningitis. Literally, that's the first thing they do. They save about 30 students a year, what he told me. God, so hard to believe, huh? Hmm. Yeah. Gone. Yeah, flesh-eating bacteria.
Well, the vaccine is to prevent meningococcal B strains.
Gonococcal B.
Meningococcal B strains.
Meningococcal.
The meningococcal vaccine.
Yeah, if you're going to work in the ER, Mike, you really ought to consider getting vaccinated. How is it spread? It's spread by coughing or what? Respiratory droplets? I think it's respiratory droplets, right? Neisseria meningitis? Is it respiratory droplets? Yeah, I think it's wise. Yeah. Well, for those of you watching, we're using the laser to vaporize and remove the herniation, but also what I'm doing is I'm cleaning up the annular tear so it's going to be able to heal on its own. Once this patient gets discharged, the healing will start immediately, and the healing will take a full year to complete, but most people can return to work within a day of having this surgery done. And what you're watching is the glass fiber of the laser, which transmits the laser energy down to the herniation through a fiber that runs from the laser machine, which is the size of a dresser, like a bedroom dresser or cabinet. It's pretty big. So the energy runs from the laser machine all the way down the fiber to through the endoscope to the tip of this little wire, and I actually control the movement of this glass wire so that I can direct the energy beam where I want it. We're just about done with this level. In 1 minute I'll be done. You can see the epidural fat there. Just want to get a little bit of the stuff lateral. What'd you find out? Respiratory?
Respiratory, pretty much.
What's the first symptom? Headache?
Let's see, symptoms.
Treatment of choice?
Silent symptoms.
Sinus?
Let me see this. The most common symptoms. Obviously, fatigue, fever, headache, and neck stiffness.
Neck stiffness, headache, fever, fatigue. Treatment of choice, is it still Cipro or what? Levaquin? Doxy?
My understanding was Rocephin.
Rocephin, IV. That's probably right. It goes in quickly.
Cephalosporin, third generation. Rocephin.
Third generation. All right. All right, we're done here. Let's get this fiber out, laser off. So we just finished up the L23 disc, and you can see the nerve root right there in the foramen. Okay. You see where the herniation was right next to it. Are you saying something, Zach? I can't hear you. 2, 3. Yeah. We're going to do 5-1 next. Scope off. Good. I need a little light where I'm working. Please. All right. I got it. So the really collapsed one is 3-4, right? So we're going to do 3-4 last because it might bend our tube. All right, so guide wire. You want to take the stylet? And let's get back into a lateral position. Luis, you hold this. Watch your hand. Yeah, push down. Right here, nice and firm.
Yes, sir.
What questions does the audience have for Dr. Deuk-Majan?
None yet, looks like.
Hmm?
None yet.
None. Zach, are you whispering answers into their ears while I'm working?
Nope.
Unbeknownst to me, shot. Shot. I know I probably have a few top fans. Is that what they're called, Zach? Shot.
That's correct.
I'm not going to mention any names, but I know they're out there, probably watching. I need my top fans to generate some discussion here. Ask an insightful question. Challenge me. Just don't make me look too bad. Shot.
My mother
Oh, is that right?
Yeah.
Where does she live?
Puerto Rico.
So Dr. Santiago's mother watches the surgeries. Hello, Mrs. Santiago. I'm Dr. Deuk Majan, and it's a pleasure working with your son. I wish you would talk to him and tell him we want him to stay here because he's a very, very good doctor. In my opinion, one of the best anesthesiologists I've ever worked with. So if you can pull on his ear a little bit, take his car keys away, whatever you need to do, bribe him. That's right, make it happen. For the patients.
We do have a question.
Yeah, shot.
We have a viewer asking about the difference between Rocephin and Cipro in dealing with coagulation.
Rocephin versus ciprofloxacin in dealing with coagulation. Okay, I'm going to do my best. So, I assume you're talking about the case we were discussing a few minutes ago. I'll just say yes. It probably is. There's a big tear in 5-1 because this thing is going in pretty easy. Shot? Alright, I'm going to have to take this out. So we're not really talking about Rocephin or Cipro for coagulation. We're talking about what's the most effective treatment for a bacteria that is called Neisseria meningitis, and it's a bacteria that basically is transmitted from respiratory droplets from coughing and sneezing, and the person inhales those respiratory droplets from someone who's infected, and then the bacteria gets on their nasopharynx or oropharynx, and I don't know if it has the ability to pass through the membrane, the mucous membrane, but somehow it gets through the mucous membrane and gets into the bloodstream of the person, of the patient. So once it's in the bloodstream, it starts to grow and divide and make more bacteria, and the person gets very, very sick. And one of the things the bacteria does, is it a gram negative rod? Neisseria? I can't remember. So it's a gram negative rod, meaning it has LPS, which is called lipopolysaccharide. It's a coating around the bacteria that promotes coagulation. It causes the host animal, the human, coagulation system to be activated. And that causes blood clots shot to form throughout the person's body within their bloodstream, which then causes all their blood vessels to clot off. The small ones, the big ones shot, which is really bad because then you get no blood supply. Why am I having that? So if all your blood vessels clot off, there's no blood flow anywhere in your body, and whatever the blood was going to is going to die. So your brain can take about 5 minutes of no blood flow, and then you're going to die. That's clogged up. So what happens in these poor patients is that the blood doesn't get downstream to the tissues that need it. As a result, their tissues become ischemic, meaning they don't have enough oxygen or sugar, and they undergo what's called necrosis, ischemic necrosis, which is where cells die from lack of oxygenation or lack of oxygen or lack of glucose. That's what we're talking about. So Neisseria meningitis is a disease caused by a bacteria called Neisseria meningitis, which is a gram-negative rod. So what we're talking about is what's the best antibiotic to use to kill this bacteria quickly. And
Rocephin or a third generation cephalosporin.
yeah, we found that it's Rocephin or a third generation cephalosporin. Cephalosporin is a type of antibiotic, and the first ones ever made were called the first generations, and the second generation I think includes Rocephin, right?
It's a third generation.
Rocephin is third generation wipe, and there are other third.
The spectrum of coverage is it's more, it's more broad spectrum.
Yeah, broader spectrum, of course. So, and then fourth generations like cefepime, which we use in cases where there's infection in the CSF around the brain. So basically, the third generation cephalosporin is the treatment of choice. It means it's the best antibiotic for killing the bacteria rapidly. The faster you kill the bacteria, you shut down their reproductive strategy. They stop dividing, growing and dividing and making more. And that's the best treatment, IV, intravenous. Intravenous Rocephin. So it really has nothing to do with stopping the blood clotting. It has everything in the world to do with getting rid of the cause of the blood clotting, which is the bacterial membrane, the lipopolysaccharide membrane of the bacteria, which is found on gram-negative rods, gram-negative bacteria, particularly gram-negative rods. I think Neisseria is a rod, or is it a cocci? I can't remember. So it's a gram-negative coccus, right? Coccus, round, rather than rod-shaped. All right,
We have another question.
sure.
We have here asking, what are the dangers and risks of this type of procedure?
So somebody's saying, what are the dangers and risks of this procedure we're doing right now? This procedure is called the Deuk laser disc repair. It's endoscopic spine surgery. Endoscopic spine surgery means spine surgery done through a tiny little tube using a camera and a scope, which is a long cylindrical tube to be able to see inside something. And the risks of endoscopic spine surgery really are the same risks as open surgery, with the exception that there's no implants or hardware, so we don't have any risks that you normally would get with spine surgery when the surgeon's putting in screws, rods, or a metal plate. So we have risk of infection, we have risk of dying, risk of pneumonia, heart attack, stroke, bleeding, hemorrhaging. We have a risk of failure to improve the patient, and the patient doesn't get any better, or they get worse. Risk of basically infection of the spine or spinal fluid or the wound. So there's a lot of bad things that can happen. You could even die. Those are all typical risks of any surgery. And the Deuk laser disc repair is no different from those other surgeries, in that these patients could, any of those bad things could happen. Now, in 13 years I've been doing this surgery, I've done 900 of these surgeries. And each surgery I do on average 2.5 discs. So, what is that? 900 times 2.5? About 2,500? 2,400, something like that. About 2,500 discs that I've done in 13 years. I've had 0 complications. So what's unique about the Deuk laser disc repair is that The risk of complications is the same. In other words, or the types of complications are the same as any spine surgery. The risk, though, is very low of any of them happening because it's a very safe surgery. And as long as it's done properly by a well-trained surgeon, then, you know, the chance of something bad happening is low. Certainly lower than open surgeries. Standby laser. Grabber. I hope that answers your question. There's other things like blood clots, spinal cord injury, hematomas, which are more blood clots, DVT, pulmonary embolism. There's just a lot of bad things that can happen. But in 900 patients, not a single complication. That's pretty darn good. That puts your odds at about 1 in 1,000 of having a complication with this surgery. So thank you for asking. It's a great question. So right now we're zapping away the herniated disc. It's kind of stuck in here where the annulus fibrosus is. And I'm doing what's called an annular debridement. The Deuk laser disc repair is the only surgery in the world that does an annular debridement. It's the first surgery in the world to describe an annular debridement. There's no other surgery that does this. And we published the annular debridement back in 2012 in the Surgical Neurology International. That's where we published the surgery for the very first time. It's been published numerous times since then. And I've presented the surgical results to the pretty much every single spine and neurosurgical meeting there is. And it's funny, of all those surgical meetings I've gone to and presented my research and my results, everyone has really been very excited about it. But I haven't had a single surgeon come to me and get trained. And I think part of that is, well, as I said earlier today in the first case, most surgeons are used to doing fusion surgeries, and quite honestly, they make good money doing fusion surgeries. You know, I make a heck of a lot more money doing a fusion surgery than I do one of these laser surgeries. But that being said, the laser surgery is really the best surgery in the world for patients, much better than a fusion. So, unfortunately, until these laser surgeries pay the surgeons better, I think we're not going to see very many surgeons wanting to do these surgeries. Plus, it's very expensive to buy all the equipment to do the surgeries, and it takes a long time to train. To be a really good endoscopic spine surgeon, you need about a year's worth of training. And the problem is all these surgeons are already out, you know, in practice, wherever they live. And for them to leave home for a year and come train with me, you know, leave their family or even take their kids out of school or whatever it is they got to do, it's just not very likely, you know, that that's going to happen. So the reality is this surgery needs to be taught during residency and during their fellowships. And again, for that to happen, the residency has to offer the surgery. They need a surgeon who can do it. And right now there's no residency in the United States except for one, and that's in New Mexico, one that Dr. Anthony Young created that teaches endoscopic spine surgery. That's the only one. So that's a new residency, and Dr. Young had to donate millions of dollars to the hospital and the university just to get them to offer this type of surgery for training. So it's pretty interesting situation, to be quite honest with you, where the surgeon is teaching this residents but has to donate $1 million to get this hospital to be willing to buy the equipment to do it. You know, it just shows that hospitals these days, they don't have the budget to buy equipment. They have to save money, and I found the same thing to be true where I'm at here in Florida. I went to the main hospital that I worked at, that I operated at, and I said, listen, let's buy this equipment. It's about $2 million. And they said, no, we don't have the money for it. We don't have the budget for it. So I did it myself because I believed in the technology after I came back from Korea and Germany, being trained by the Germans, Koreans. So I just borrowed the money from the bank and I bought the equipment and started doing the surgeries. That was 13 years ago. But the truth is the hospitals just don't have the budget for it. Now I am seeing some hospitals these days that are spending a lot of money building spine centers of excellence. Like one apparently in Ohio is opening up a $60 million spine center. But what's funny about it is the surgeries they're going to do there right now are nowhere near as advanced or sophisticated or as good of an outcome as what I'm doing right here. That's what's incredible. That hospital that's opening a $60 million spine center is, I would have to say, 20 years behind right now. And the thing about it is they don't even know it. But that's just the way it is. Yeah.
We have a viewer asking, I've had a radio frequency nerve ablation on L5S1 every year for 9 years, and it seems to be working.
Good.
MRI shows a bulging disc. Would you recommend keep going with the treatment or having it fixed permanently with a surgery like this disc repair?
That's a great question. And thank you for asking. So we have a viewer who's asking a really good question, and it allows me to talk about some key things. So they've had back pain in the past. They had a procedure called a rhizotomy, which is a procedure where the surgeon will basically burn a small nerve that goes to the facet joint, and it's used to treat pain that comes from the facet joint. Well, the facet joint is not the disc. They're two completely separate areas, but they're separated by a few millimeters, maybe a centimeter at most. Anyway, most pain comes from the facet joint, and this person who's asking the question clearly had pain coming from their facet joint. They had the appropriate treatment, which is a rhizotomy, 9 years ago, and they did great. And they have no pain, apparently, right now. So they do have a bulging disc on their MRI, and they want to know, should I just get that bulging disc fixed? The answer is you should get whatever is causing your pain fixed. Okay? So if what's causing your pain right now, today, if you have pain, is the facet joint, then you should not get the herniated disc fixed. What you should get fixed is your facet joint. Okay? So what I'm saying to you is if your pain that you're having today is coming from your facet joints, which is easy to figure out, you just do a diagnostic medial branch block or a facet joint injection. If the pain is coming from that facet joint, do not operate on the disc. I'm having trouble twisting it. Is it? A little bit. So, on the other hand, if your pain is coming from that herniated disc, then you should do the Deuk laser disc repair, what we're doing right now. That's the best treatment in the world for it. On the other hand, if you're having no symptoms at all, then don't do anything. Just enjoy life and do the things you want to do. That's my advice. Don't do any surgery right now if you're not having pain or symptoms from either. The key here, folks, is to treat the source of the pain. Don't treat the MRI, treat the source of the pain. And this is why there are so many people with back pain and neck pain, because the doctors are treating the MRI and not the patient's source of their pain. All successful pain management doctors share the same belief as I do, which is you only treat the source of the pain. And a herniated disc does not cause pain about 95% of the time. They just don't cause pain. So why operate on a herniated disc if it's not causing any symptoms? Okay? That's the fact, Jack. Hopefully that makes perfect sense to you. Just about done at L5S1, and then I gotta go on to that. The really difficult level. All right. Dr. Santiago is gonna make sure our patient is really comfortable so he doesn't tighten up his back muscles and squeeze down on my tube and crush it. If I lose any more of my equipment, I'm gonna have to go back to the bank and ask for money. And that's one thing I hate to do. I tell you, I'm so upset with my banker. By the way, if anybody out there wants to sponsor an up-and-coming race car driver, just let me know. It's not me, by the way. It's actually my son. All right, we're going to be done at this level in 1 minute. 1 minute. All right, I think we're done here. Stand by. Let's take a look. Should be a nerve root right there, and there it is. That's the dorsal root ganglion. That is the right L5 nerve root. And there's the herniation. Actually, give me the laser back. I want to get a little bit more. Yep. Get ready with the laser. Thank you. As soon as I pulled the tube out, I noticed there's a little more I can get. He might start feeling this. We're right up against his sinovertebral nerve. All right, I'm happy with that. Am I? Ah, it's good. Laser off. All right. Scope standby. Happy juice. Folks, we've done 2 out of 3. That was L5S1. Not an easy one to get to. But the next one is the L34, correct, folks? L34. Yeah. That's kind of why we leave the needle in, because otherwise I wouldn't remember which ones I've done. It kind of helps me remember. So I'm just applying some pressure to the paraspinous muscles, just making sure we don't have any intramuscular bleeding. We want to minimize that. So 5, 4, 3, 3, 4. Okay, guide wire. Last time the guide wire will go in. Bring the fluoro in. Nice. And shot. That's it. All right. Shot. I can't tell. Shot. All right, yeah, so it's there. Good. It's gonna be a fun one. I can't even get the needle out, it's so tight. Oh my lord. Yeah, a lot of bone spurs here at this level, and just the makings of a good time. All right. Save the best for last. Stay on. Shot. That's it. All right. Shot.
We have a question.
Sure.
We have a viewer asking, what are the chances of a spinal cord leakage with the laser surgery?
What are the chances of a spinal fluid leakage with the laser surgery? All right, so I'm going to answer your question first, which is the spinal cord leakage. I assume you mean spinal fluid leakage, but if you did mean spinal cord, the chance of spinal cord is 0 with this surgery right here, because the spinal cord is nowhere near where we're operating. The spinal cord is higher up, and we're operating well below the spinal cord. But if you meant spinal fluid leakage shot, then the chances are real. I mean, we could have a spinal fluid leak. But here's the problem. You're asking me the chance of a spinal fluid leak in a surgery that I've never had a complication in. So I'd have to say 0. But then again, that wouldn't be honest and fair, would it? Because you could still get a spinal fluid leak even though I've never had one in my career doing this surgery in 13 years. So if I had to guess, I'd say if I'm doing the surgery, maybe 1 in 500. If someone else was doing the surgery, like Luis, for example, I'd be about the same. No, but seriously, it depends on your surgeon. I'm telling you, if you don't understand that, it's a very important concept. The surgeon that you choose for your surgery is so important that you pick a good surgeon, because I'm telling you, there are surgeons out there that 50% of their surgeries are major complications. Okay? And there are surgeons where, you know, they almost never have complications. It's not that bad. I don't think it'll crush the tube. So there's another spine group in our town here, which I'm not going to mention their names, but patients that have spine surgery with them, they die. Quite literally die. They get about 2 or 3 patients dying a year. Now, I don't have any patients dying. And their surgeries they do are less complicated than the ones I do by far. I do very complex spine surgery. So I'm just telling you, trust me, I do a lot of medical malpractice defense. I defend surgeons against lawsuits. There's a lot of stuff, but the problem is it's considered okay. You know, it's considered normal, but for me it's not acceptable and it's not normal. So where you go determines your complication. Which doctor does your surgery, what environment you do it in, hospital versus, you know, a surgery center like the Deuk Spine Institute, you're going to have a much better outcome than a hospital, because hospitals have lots of infected patients with bugs everywhere, and they don't have the latest equipment like we do. That's perfect. I think we're good, and it's not too much pressure on the tube, so whatever you did was magical. Like I said, the best there is. I had one anesthesiologist I worked with years ago. Sad, Dr. Kim, Korean, South Korean. Amazing. Never talked once. You know, quiet. You could talk to him and the guy would just like, but he would never talk back. So it was as boring as you can imagine. It was like talking to a wall. But the patients always did well, and they literally, they would start moving when you were putting the bandage on. So they was extubated, recovered like within 5 minutes. He was amazing. He died though. He died of a heart attack. Young, like in his 40s. Sad. Really, really, really sad. But I thought he was one of the best anesthesiologists I'd ever worked with. Okay, yeah. Let's get this show going. We are just about done. This is our last disc. So how many incisions did I make anyway? 2? Yeah. So we got 2 incisions. They were pretty close to each other. I could have done something with the incisions, maybe like, you know, made them go up instead of sideways, but I don't like to change what I do. Surgeons, really good surgeons you'll find, they do things the same way every time. And there's a reason. Probably anesthesiologists the same thing, right? There's a reason. We know what works in our patients, and we want to get consistently good results, so we do it the same way. When you have a surgeon who's like, yeah, we'll figure out what we're going to do when we get in there. No, that's a really bad idea. A really bad idea. You never want a surgeon who figures out what to do while they're in there. I mean, a surgeon should know ahead of time, unless, of course, it's an emergency and the patient's dying and they have no choice but to move quickly. But all my patients, for example, that have surgery, I meet them all in the clinic. I go over their MRI, their nerve test, their x-ray, their CAT scan. I do an exam. I make sure that what I believe needs to be done is done. And then when I get to the operating room, I just do what I plan to do from the beginning. I know what needs to be done before surgery. So every good surgeon that I've ever worked with is the same way. They don't kind of wing it. Now, you know, some surgeries that we do as neurosurgeons, you have to be prepared for some very bad things to happen, right? If you're clipping an aneurysm, for example, you have to get what's called proximal control of the bleeding, which means that you may have to open someone's neck when you're operating on their brain to stop the bleeding in the brain, because the carotid artery feeds the brain, and if the aneurysm pops or you lose control, you're going to have to get in the neck and open it up. So sometimes you have to do things in neurosurgery that maybe you don't know for sure you're going to need to do it until you get in there. But when it comes to elective spine care, like fixing someone's back pain or neck pain, the surgeon should know each and every time before surgery about 99% of what they're going to do. There should be no, I'll look around and figure it out. And you should not wake up with surgery being done that you didn't expect to be done. For the most part, surgeons really do need to stand by. They need to be able to tell their patients ahead of time what they're going to do. Any reason why my lens is looking this bad right now? I think we're gonna need to. Because I don't think we bent the shaft, right?
No,
Is this the new one?
no, it's not a
Good. I'm glad you're not using. I like saving the new ones. Let me see. That's pretty good. It looks clean there. All right. So great questions from our audience. You have any more, Zach?
We do have another one. We have a question. They're asking, what is the healing time frame for the surgery and what type of therapy is needed?
What's the healing time frame for the surgery? I see this. We sped it up a little bit, and that's okay. The laser? I don't mind it. The healing time frame for the laser is going to be basically, I'll break it down for you. So somebody's saying, what's the healing time frame for the laser? So the skin incision that we make is going to heal in a week. The cut, like right here, the annulus that I'm debriding, that's going to take a full year to completely heal. A year from the annulus. A week for the skin, and then of course there's the muscle, which takes 2 weeks to heal. So there you go. 1 week for the skin, 2 weeks for the muscle, and a year for the annulus to heal. Why does the annulus take so long to heal? Anybody know? I know Dr. Santiago probably knows. Who said that? Who said something? I heard somebody say something. No, low blood supply. That's exactly why the annulus takes a year. That was my x-ray tech. Great job. Very nice. Smart. You ready to go to medical school? She says no. Yeah, you're right. So the reason the annulus takes so long is it doesn't have any blood supply. So things without blood supply don't heal quick at all. Yeah, that's why diabetics that have very bad blood supply, they take forever to heal ulcers and things like that. That's why nobody wants to operate on a diabetic. Too many wound complications, right? They have to use hyperbaric oxygen chambers. Ah, that reminds me, I need to look on Amazon for a hyperbaric oxygen chamber.
You getting one?
Yeah, I'm thinking about it. I have some experiments I need to do.
I thought you were going to start treating ulcers.
I need to find a way to push fluids into a space under pressure. God, I hope I didn't do anything. So I guess maybe not a hyperbaric oxygen chamber, but something similar. A pressurized chamber. I totally forgot about that. I get these crazy ideas when I'm laying in bed at night, and half of them I forget about because, well, I just fall asleep and I never remember until somebody reminds me, like just right now. This is a pretty bad disc for those of you watching. Stand by, let's wipe the tip. Wipe. Not with the blood. Not with the blood. Did you see that? Luis?
Yes.
Dígame, dígame. Okay, dígame. There we go. Talk to me, my man. Don't just stare at me wide-eyed like a deer in the headlight. Say, yes, I understand. Yes, I understand.
Yes, I understand.
Thank you. Perfect. I love it. So happy. Yeah, if you're cleaning the scope, you don't want to use a bloody Raytech. Fuck. Is this a fresh bag of saline?
Yes.
Is it super cold? Is that why I'm getting fogging maybe? Sometimes when the saline is like really cold.
It's chill. It's not as cold as your first bag.
So it's not as cold. Because I was going to say it looks colder. It actually feels colder on my fingers. Let me ask you a question. The first bag, how long was it sitting here before I used it? In other words, when was it brought into the room?
It was running to the room at,
No, I don't need a time, but it was a while before I got here, right?
it was probably.
It was a while before I got here.
In 15 minutes.
Before I got in here?
No, before you got to it.
So that then it really did warm up quite a bit, right? So this bag is fresh out of the refrigerator,
Yes.
so that's probably why. It is colder. It's so hazy. I just hope the lens is okay. It's gonna really stink if it's not. Well, I've got about 5 minutes left, Dr. Santiago.
Would you like me to switch to the other bag and see if that clears it up?
No, we're okay. I can operate in haze. I'm from Los Angeles. I'm used to doing things where the smog and haze block your vision and sting your nostrils and eyes. So this isn't so bad. Man, here it is. No matter how degenerated the disc is, there's always a tear at every painful disc with this material. So anybody see any good movies lately? Isn't the Godzilla movie out yet? Gosh. Anybody see the Godzilla movie? Huh? Is it out? Oh, it's not out yet? Okay. But it's not in the theaters out yet? Whew. You're gonna hate me, but there's a big bone spur here. What's that, guys?
That's just me moving stuff in.
That's how you move things? I'm just kidding. Standby laser. I'm just having fun with you. I hope you don't get angry.
We have a question.
Sure.
We have a viewer asking, would you recommend having bone spurs removed, and what are the chances of them coming back?
So do I recommend having bone spurs removed? So the answer is only if they're causing symptoms should bone spurs be removed. So the first thing I need to do is I would need to see your MRI, X-ray, or CAT scan, whatever you got. I would need to know what kind of problems you're having. You know, where are you having pain? Are you, if you're having a pinched nerve and the bone spur is the cause of it, yeah, should be removed. If you're not having a pinched nerve and you just have a bone spur, then absolutely not. Leave it alone. The only time we remove bone spurs is if they're causing symptoms. Like right here, this one, right? This one is right where the nerve is. So I have to get rid of it. So I hope that answers the question. Only remove bone spurs that are causing symptoms. That's my recommendation. And by the way, I'd be happy to look at your MRI for you, or your CAT scan or X-ray, whatever you've got, and help you decide. Anybody out there, and not just this person, but anyone with an MRI, X-ray, CAT scan of their spine, that they want my advice, I give it for free. I don't charge a dime. You just have to submit your MRI for review to Duke Spine Institute on our website, and I will look at it, and I will even give a recommendation about what I think can be done based on your symptoms. So we're going to need to get some information from you, like where is your pain, how long have you had it, what have you done to treat it. All those questions give me information. I actually pay attention to them, believe it or not. And when I review your MRI, I try to put it all together, standby laser, and figure out what's causing your problem. And we do make a recommendation, all for free. And then the other thing we do that's free, that's very helpful to people, is a video chat. So we do a video chat for free. Basically, let me have that. Yeah, thanks. We will get online with you and do Skype. And I'm actually the one who does it. So you get me, Dr. Duke Machen, on the phone with you on Skype for a good 10-15 minutes. No charge. Why? Why not? Right? Why? Because I can. Why? Because I want to. Isn't it nice to be able to say that? Why? Because I'm the boss, so I get to. Yeah, and I choose to. I choose to do things for people and not charge when I can. Obviously, I have bills to pay, so I think an MRI review and a face-to-face conference is nice for people to be able to have that and not have to worry about paying $1,000 or whatever for it. You know, it's a service that I just provide to the community, to the world, for free, because I really want people to know that there's a way to fix their problem, and maybe even talk to them a little bit about it. Some people will do it, some people won't. That's okay. Even if 0 people listen to me, 0%, it's still okay. Why? Because I have a responsibility to try to help people. I can't see anything now. All right, let me take the laser out. Let me have the grabber. Yeah, so I'm going to try to slow down this oozing of blood. It's hurting my vision. All right, I think I see right there. Right there. All right, let me get the laser back in. Yeah, I really derive pleasure out of helping people get out of pain. About topic that I know about, you know. So that's why we do it. We don't get any government funds. We don't get any subsidies. We don't get any charity payments. We get nothing, basically, but satisfaction of knowing that we've made ourselves available to help another human being end their suffering. That's really what it comes down to. I just know there are people who would not be able to afford to pay for it. And so rather than try to figure that out, standby laser, we just do it for free for everybody. Whether or not they have a means to pay for it or not. I wish I could do all the care for free. I really do. Nothing would make me happier. But nobody's come over and donated money for us to take care of people. I don't know where Mark Zuckerberg is or Jeff Bezos, but these are the kind of people that could end back and neck pain overnight if they wanted to. If they just contacted us, we could help them. I mean, that's huge. You go down in history to partnering with us to do that.
The part on their neck is not hurting.
Yeah, right. Exactly. All right, I'm pretty happy. That's the end plate, by the way, at 12 o'clock. That's the surface of the bone, the flat bone. That's where the disc is. So there's the disc, and I feel like we've done a pretty good job here. Let me just take a peek. That's the epidural space. We're outside the disc. I feel like we did a good job there. Let's see if I can see the nerve root somewhere up here. Too much fat. There's the root right there. See it? That's the nerve root, the white thing on the side of the fat. So good. Oh, there's a little piece there. Let me grab it. And we're done. So let me get that piece out. Zach, I'm going to head over, and if there's any other questions, be happy to take them. Got a good eye, Dr. Santiago. A really good eye. I think you'd make a great surgeon.
I like to watch what you guys are doing.
You pay attention.
Yeah.
That's because you care.
Because you guys are doing over there. is
Standby laser.
job. Yeah.
Good for you. All right, I'm going to head over and take any more questions our audience has. We'll wrap this surgery up. I've got my main man, Luis, here, and Dr. Santiago and the rest of my team. Thank you for your help today. Appreciate it. Everybody, great job today. Sorry it went so late. What time is it anyway? What is it? 6:56, almost 7 p.m.? My God. I'm getting slow. Actually, these are long cases. The 3 level, 4 levels. Oh yeah, the R phase too. So we did quite a bit. All right, I'll be over there in the conference room in 5 minutes, and I'll answer any more questions you have. So start typing. Don't write a novel. Okay, Dr. Deuk, I'm back with you live with Zach and Karen Foley sitting next to me with her snazzy boots. Those are cool. Really nice. I like that. Anyway, I'm here to answer any questions you might have about the surgery we just did. And we did a Deuk laser disc repair lumbar spine, which is the lower back, in a patient who's been suffering with chronic back pain in his back for years, and it goes into his leg. I think on the right side is what we did, and we had to fix 3 discs. He's had a prior fusion many years ago. Did not want another fusion. They're too painful and too many complications. So I don't know if any of you are physicians or nurses out there, or radiologists, or anyone with a licensed healthcare background, but you may have noticed at L4-5 that there was a fusion between the L4 and the L5, and that it was an absolutely horrendous looking fusion. And I'm sorry, I know the patient will be listening to this afterwards, but it's the God's honest truth. When you fuse 2 vertebrae, you should fuse them with the proper curve, the curvature. We call it alignment. And there's really 3 axes that you have to pay attention to, right? So there's lateral bending or twisting, which is scoliosis, and then there's the we call sagittal alignment, which is the curve of the spine if you're looking from the side. And in the lower back, you want lordosis. And then there's, of course, the height of the disc space at L4-5, where the fusion was done. Now, I did not do this fusion L4-5. It was done many years ago by some other doctor. But I can tell you the doctor did not properly align the spine by putting a spacer between L4-5 and jacking L4 and L5 apart to create lordosis and foraminal height. He also did not untwist the spine at L4-5. So the L4-5 segment's fused, but it's twisted, it's collapsed, and it's kinked forward. So what's happened as a result of that bad fusion, and I'm telling you this because I see it all the time. It is the number 1 cause of adjacent segment disease in the spine. It is poor alignment at the fused segment. No one's ever described that before. I am literally the first person to say it. Everyone always talks about adjacent segment disease as, oh yeah, it just happens naturally. You fuse one segment, and then it puts more stress on the next one, and they're going to come in, and they're going to have surgery at the next level. Well, that's not true. And I figured that wasn't true in my patients because I always achieve excellent alignment when I do a fusion. And when you achieve excellent alignment, the risk of your patient coming back and having to have another surgery is less than 1%. Whereas if you look at the literature with respect to adjacent segment disease and the need for additional surgery above or below the fusion, the rates are as high as 20-30% of patients. So why is there a difference? There's a difference because most surgeons do not care about alignment. They don't properly align the spine when they fuse it. As a result, the alignment's off. The patient's trying to correct for that or compensate for it at the segment above or below the fusion by untwisting, so they're twisting the opposite way, or by unkinking, so they're pulling their back hard, and that causes the bones to slip and the disc to fail. Long story short, it's actually the surgeon's horrible fusion that they did that causes adjacent segment disease. So all this time, I've been led to believe, as is everybody else, that it's a natural history of the patient's spine just to degenerate, but it's really not. It's most of the time, vast majority of the time in my experience, it's improper alignment of the spine when you fuse. Anyway, just a little digression, but very important. Our first question says, what could be causing sciatic nerve pain? In pain for 3 years now and haven't left my house. So one of our viewers says, I'm having horrible sciatic pain. I can't get out of my house. I can't live life. Life sucks. Come here to Deuk Spine Institute is my answer, and let us fix it for you. What causes sciatic nerve pain? The vast majority of the time is going to be a pinched nerve, either L2, 3, 4, 5, or S1. Typically for sciatic pain, it's going to be L4, L5, or S1 nerve root. So where is it getting pinched? The most common place it gets pinched is in the spinal canal, neuroforamen, lateral recess. Basically the kind of areas that I operate on all the time with the endoscopic surgery. Where else could it be pinched? It could be pinched in your pelvis if you have a pelvic tumor, which is extremely rare and unusual, and I don't think that's the cause, but it could be. It could also be pinched in your butt cheek in the muscle called the piriformis muscle. If you have a torn muscle, it could be irritating the sciatic nerve, causing sciatica. So there's a few places where the sciatic nerve could be impinged upon and cause sciatica. We know all of them at Deuk Spine Institute. We know how to figure out which one you have, and we know how to fix it. That's the message. What's next?
How much time after this surgery does it take to get back to normal activity if everything goes well?
So someone's asking, how much time after the surgery does it take to go back to normal activity if everything goes well? First of all, I expect everything to go well. The biggest hurdle after surgery, to be honest with you, is therapy, physiotherapy. Why? Because it's kind of a pain to do. You got to take 2 days out of the week, not even 2 days, but like 2 afternoons, and head over to the therapy office and get stretched and massaged and recondition your muscles. So that's kind of the most challenging thing after the surgery, is just the commitment you have to put into rehabilitating your muscles and your joints after the surgery. And I'm telling you, that's the most important thing you got to do, because without it being done properly, people will continue to have muscle aches and pains. So you got to do the therapy. The nice thing about the surgery, the Deuk laser disc repair you just watched, is that there's no narcotics involved. No opioids, no narcotics, no powerful painkillers like there is with open surgery. Every other type of surgery, patients are taking pain pills afterwards, getting addicted and getting sick, nauseated, ileus, blah, blah, blah. So one of the nice things about the surgery is our patients usually take Tylenol, or they take a mild anti-inflammatory, all right, like not Toradol, but I can't remember the oral version. Anyway, that's what we prescribe. So our patients usually take an anti-inflammatory and Tylenol, and they don't need to take any powerful painkillers. So recovery is very, very quick. You say regular activities. If you're talking about, if your life doesn't involve heavy weightlifting or CrossFit, marathons, things like that, then you can get back to regular activities within a day or two. On the other hand, if you are really into very physical sports, which is fine, you're going to have to give yourself a little more time to heal. And now you're talking about several weeks to maybe even a month or two before you can get back to those normal activities. So it really just depends on what you consider to be normal activities. As long as it's just normal stuff, that not really stressful physical activity like playing football or, some type of a competitive sport, then you can get back to normal life within a day. If you're talking about, aggressive sports, then you're looking at, depending on the sport, depending on how many disc herniations you had that I had to fix, depending on the condition of your core muscles, whether they're strong and supportive, depending on whether there's any instability of the spine, such as listhesis or scoliosis or collapse. I mean, those are all factors that I look at when I tell people how long it's going to be until they get back to their more rigorous and aggressive activities. So normal activity, I'd say a day or two.
What's the good treatment for neuropathy, nerve damage, ankles are very dark?
All right, we have someone saying, what's a good treatment for neuropathy? My ankles are dark from nerve damage. So a couple of things to think about. First of all, really the vast majority of patients with neuropathy that I've seen and treated, they don't have dark ankles. So I don't know why your ankles are dark, but I would be concerned that you may have what's called venous stasis disease. Venous stasis disease, otherwise known as venous hypertension. Look it up on Google, venous hypertension in your legs. And what that does is it causes these hemorrhages, microhemorrhages, which leak blood into underneath your skin, and that turns your skin dark in your legs, okay? So that's venous hypertension. It can also cause numbness, tingling, even burning in the skin. It's very easy to fix. It takes a laser, and we go in and just fix the valves inside the veins and kind of shrink up the veins and let the valves do their job. So the disease is very common, and it leads to darkening around the ankles, and it causes burning and tingling in the skin and the calves. It's often mistaken for neuropathy. So, as far as neuropathy goes, neuropathy is really damage from a chemical problem in your body. We call it a metabolic problem to the fine nerves in your skin. These are tiny little nerve hairs. And unfortunately, there's no cure for neuropathy in the sense that once you have damage from neuropathy of your nerves, there's really no way to get it back. So it's really important for people with neuropathy that they invest the time and money and effort to finding a good neurologist to figure out why they have neuropathy. The most common cause in the world is diabetes. Second most common is probably a low thyroid hormone count. Another common cause is alcohol consumption. As a matter of fact, there's a whole list of causes. You need to go see a good neurologist and talk about why you have neuropathy. But make the right diagnosis, fix the problem. Sometimes hormone deficiencies cause neuropathy. So if you've got a hormone deficiency, get it fixed. That way your neuropathy will stop getting worse. As far as treating neuropathy, the symptoms, a lot of people take pills. Some of the more effective pills are like gabapentin, or Neurontin is another name for it. Another is Lyrica. Those are pretty common pills that are used to treat neuropathy. An older one is called amitriptyline. But I'll tell you, I've had some patients tell me they use turmeric. Turmeric has been apparently very effective at treating neuropathy. That's a non-medication treatment. It's holistic, over-the-counter turmeric. So give that a try. So we have somebody who's 5 feet 9 inches, 270 pounds. Can they have the surgery? The answer is yes, absolutely. You can have the surgery if you need it. So the first thing we need to figure out is, do you need it? And if so, where do you need it? Is it 1 disc, 2 disc, 3 disc, 4 disc? So what I'd like to do, if you're interested in, is get us your MRI scan. If you don't have one, come in. We'll do one here. If you're from out of town, then get an MRI done. We can help you with that. And I will review it personally. I'll do a face-to-face chat with you, and we'll talk about what needs to be done to fix your problem. And then you can decide if you want to come out here to Deuk Spine Institute in Florida and get your back fixed. For those people considering traveling here for back surgery or neck surgery for herniated disc, I think it's an excellent option. I would recommend it. We actually have Disney in Orlando, 45 minutes away, basically. We have Universal Studios, we have water parks. Basically, you can come out with your family, get your back or neck taken care of with an outpatient endoscopic surgery, and let your family go and enjoy Orlando. Orlando is the #1 visited city in the world, 64 million tourists a year. It's the top tourist destination in the world. It's very safe. So anyway, we're right next to Orlando, and we can get you taken care of. Any other questions? All right, Dr. Deuk here. Thank you for spending time with us. And we do these broadcasts every week that we have surgery. All of our surgeries are broadcast live from Deuk Spine Institute every week, every surgery, as long as our patients give us permission to do so. Most patients are fine with it, and that's why we're able to broadcast the surgeries. So these broadcasts are free, open to the public, and we do question and answer sessions during the broadcast to educate people about what's being done in terms of advanced spine care. Feel free to bring your questions with you, anything related to the spine, whether it's socioeconomic or medical. I'm happy to answer the question for you. Our patient was doing really well last time I checked, and he'll be going home in about 30 minutes. One last question. Someone snuck it in. Happy to take it.
Do you do disc replacement in the lumbar area?
Someone asked me if I do disc replacement in the lumbar area. The answer is yes, I can do disc replacement in the lumbar area. However, I usually discourage people from having a disc replacement in the lumbar area, as I think that there are better options, including the Deuk laser disc repair. Have a good night, everyone.